Hi, everyone. I imagine most of you have been told at some point that your chronic condition is just something that you're going to have to learn to live with. No next steps, no real answers, just here's a basically useless diagnosis. But we really are wishing you all the best with this. But my guest today is a physician here with a completely different approach, and he is doing it with 20 years of clinical experience behind him, and he is equipped with the latest pain science. If you're new here, I'm Raelan, and this is where we dive into real, unfiltered recovery stories from ME/CFS, long COVID, chronic pain, and similar conditions. And to date, I've interviewed about 230 people who have completely turned their health around. And in addition to bringing you these types of stories, I'm also bringing you the cutting-edge experts in this field to help us understand how this complete recovery is done. Today, I am thrilled to be joined by Dr. Deepak Ravindran, tuning in from Berkshire, UK. And he's not just a specialist, he's what's called an upstreamist, meaning that he doesn't just treat pain, he looks at why it's showing up in the first place. And Dr. Ravindran has helped lead award-winning NHS services for pain and long COVID treatment and is the author of the best-selling book, The Pain-Free Mindset. He is deeply committed to sharing the latest breakthroughs in pain science in ways that are actually helpful and truly life-changing. This is going to be a great one, so let's dive in. Dr. Ravindran, so incredible to have you here. Thanks for being here.
Absolutely lovely to be on you with your channel, Raelan. This is fantastic. Thank you for having me.
Oh, it's one of my favorite things to get to connect with physicians like yourself who are doing this amazing work. I was saying just before we hit record, how much so many of us have struggled in the conventional medical system, and to find people that understand chronic pain and long COVID and all these conditions. So it is just an invaluable opportunity to hear about all the work that you've done and all the research you've done on this. So
Thank you for that. And probably at the outset, almost right back at you in terms of the work you've done sitting in the United Kingdom, your channel and all the lived experiences that you've collected and curated over the last few years has been really invaluable for my patients as well. So thank you for the work that you do.
Oh, so wonderful to hear. And I know that means so much when people hear that their stories matter and they're being shared, and that it's helping, because that's why people come on and share them.
Absolutely.
So if you could tell us a bit about your background, how did you get into this, and what is your role in pain management?
So, for all your listeners across the world now, I work in the United Kingdom and I work within the sort of National Health Service of the United Kingdom. I'm a consultant in pain medicine. That's my basic specialty. And I'm also a professor, honorary professor at one of the universities in the north of England, the Teesside University, with some teaching roles in the University of Reading, which is the closest one to my area. Now, the place where I work, Berkshire, is about 20 minutes west of Heathrow. So, in terms of placing the geography, I'm much closer to London in England. And I've been here for almost 20 years now with a core interest in pain management. And in my area of Berkshire, which is roughly about 700 to 800,000 population, I've been at various times over the last 15 to 18 years the lead for the acute pain service in the local specialist hospital. I've been the lead for the chronic pain service, having set up the community pain service for the local Berkshire population. And in the last 4 years, I've had the opportunity to set up sort of the long COVID service. So not only am I a practicing clinician looking after chronic pain patients, and in recent years, long COVID, chronic fatigue patients there, but it has also been supplemented by sort of the leadership aspects of setting up a service, sort of working with patients, working with other stakeholders in the community to actually create a service that helps patients and that reaches out, a lot of it within the National Health Service, but some of it within the sort of private side here as well. And that's been the journey in terms of my time here. What drew me to the work, well, with my background in anesthesia, sort of anesthesiology and perioperative care, what I was finding was a lot of pain patients that were coming to my chronic pain clinic were also coming with flare ups of their pain in the acute side. They were coming under various medical specialties, being admitted a number of days in hospital. And as you can imagine, over the last 20 years in the UK, we've seen that change from people having been dependent on opioids, being given lots of strong pain medications, all kinds of medications, then finding that they are not working or they're getting side effects or they're getting problems. And then in recent years, I found that, well, how do I support these patients? How do I help my chronic pain patients for whom injections or drugs or surgeries were not that effective and the success rate is only 30 or 40%? So, what do we do about the 60 to 70% who needed a much more integrative, holistic, or lifestyle medicine based approach? And that's kind of my work for the last 3, 4 years is how do I bring an integrated, trauma informed, upstream approach to providing a framework for all chronic pain and functional neurological disorder, chronic fatigue, long COVID, so many complex illnesses which are not really served or supported or validated or listened to by the traditional community. That's kind of my bread and butter work for the last 5 to 7 years.
This is so fascinating to hear because I can only imagine how much pain medicine has changed over the last 20 years. Do you think has it changed across the board for all practicing physicians, or is it a slow, gradual shift?
Great question, Raelan. I think it is a slow, gradual shift. And as some of your speakers that you've had recently on your channel, like Howard and Dave and a few others have commented, the challenge is a lot of the systems, the way our healthcare systems have been structured, have been incentivized, and how the reimbursement schemes, the insurance providers, all of these have rested on a very outdated understanding of pain, where everything is based on the structure of the human body as being a reason for pain or some kind of discomfort coming from. And if it's not seen on a scan, then it's almost disbelieved or not validated. And I think that's been responsible for a lot of failure of our profession as well as insurers and payers to update their models, update their ways of working. I think change is happening. There is certainly in the United Kingdom, I've been seeing, especially after COVID, where we realized, for example, conditions like COVID and long COVID have shown that there is so much that the body is going to be requiring from the local environment that we are part of, our social connections, loneliness, isolation, all of those, what we call as social determinants of health. We've now realized how vitally important they are to our understanding of mental health, our understanding of long term conditions like diabetes or obesity. And now we are seeing, and the data, as you said, in the last 10, 15 years, the understanding of pain medicine, the importance of the neuroscience, and how our neural circuits learn about threat, all of that is now becoming much more mainstream information. And that's changing how we need to be doing pain medicine. So the change is happening. It's faster in some pockets and in some systems where there are the right kind of people got together and they're making change happen. But in other areas, it's a little slower. And I think that is where patients are often falling between the gaps. And we have a particular term here in the UK, we call it postcode lottery. So, depending on some of your postcodes, you can get really fantastic care because you've got clinicians who understand the mind body connection, the connection of the spirit, and they're able to provide the right care at the right time. And in other postcodes, which might just be for a few kilometers or a few miles away, you have a still outdated system which hasn't updated itself.
Oh my goodness, I have goosebumps from that term. It is so perfect to explain what's happening for so many people. It really, we talk about there are many great physicians and clinics out there who are treating people effectively and up to date on the latest pain science. But your chance of landing in one of those offices is like a lottery. That's the great thing about this day and age, though, is that now we can have you here, deliver you straight to people's homes, even if they're not in your postcode.
And that's been the biggest joy. And I think part of that has been also been in the right place at the right time. I felt around 2016, I think, was when my epiphany moment happened, where I realized the way that I'd been taught to do pain medicine, wherein I was really good at prescribing the drugs. And if you gave me a sort of syringe and a needle, I could get to any particular group of nerves in the human body and I could block it. But I realized that that training was not adequate because I did not understand where my patients are coming from, what's happening in their ecosystem that can sometimes perpetuate and maintain their pain. And until I sort of had to read around it, realize how much of literature and knowledge is already there, that I have decided that, well, I needed to update myself. And I've spent the last 5 to 7 years sort of talking to my fellow colleagues, talking to patients, saying the same thing to a lot of patients till finally Penguin decided, okay, fine, why don't you write about it? And I got the opportunity to write my first book that came out a couple of years ago. The Audible version came out last year. And it's gratifying because now I have patients coming to the clinic saying, we saw that video of yours, we read that book of yours, and we think that we understand pain a little better now. So actually, what we are looking for is this. Can you provide us with this understanding, this help, and this signposting, which is so much of a much more useful conversation to have rather than starting at the root and saying, are there other ways to manage your pain? And they'd say, we don't know. You give us a tablet or fix my pain. But now the conversation is much more proactive, much more supporting, much more has a two-way approach wherein both of us are helping each other and making a difference.
So, what has been your experience working with long COVID patients? Because someone told me an estimate, or maybe it was you, but we have hundreds of millions of people, we're saying, with long COVID in the country, and billions of dollars going into long COVID research, which, to my understanding, not a lot is coming out of it. And I interviewed someone even just yesterday who went to a long COVID clinic in Canada, and they had him doing side planks. Like it was like a physio rehab to get rid of his long COVID, and he got worse. So it just feels like people are very lost when it comes to long COVID. But you were actually making great progress with this. So how did you sort of make that connection and that leap? And then what has your experience been working with this population?
It's a great point there because even now people are often in the UK surprised that a pain physician has taken this interest in long COVID. And indeed, sometimes I probably am one of the very few pain physicians who have been actively involved in long COVID right from the outset. And that's because I was already looking after a lot of fibromyalgia, ME, and CFS patients in my area of Berkshire. I'd set up the community pain service in 2016 and 17. So I was seeing a lot of patients out there. And when the COVID episode and acute COVID came along in 2020, I myself caught COVID in the first wave. Indeed, I was one of the first two physicians in my hospital who caught COVID. And I struggled. Those 2 weeks was intense for me. I mean, I've had my share of man flu, don't get me wrong, but that was the worst set of illness that I've had. And it took me a further 3 weeks to even start to get better. And when I came back to work, I realized that there were colleagues of mine who were taking longer, much longer than a viral infection should take. And that got me interested from a research, from an academic, from a clinical perspective, that there probably we are going to be seeing something of a post-COVID picture that would represent or that would emerge. And we were having our ICUs were completely swamped. And indeed, I thought that we needed to have a service that should support our patients who have come out of ICU. And that is what led me to work with a number of people across the UK at that time. We actually submitted a paper to the House of Lords because that was the UK government at that time trying to say, well, what do we do? And indeed, the UK was one of the first countries in the world to actually say, here's £10 million. We want to have a service where you open clinics for long COVID, for post COVID patients. And we want to see how we can study this condition better, understand this condition better. So, in that sense, the UK has been a leader in setting up appropriate, well funded services across the entire England. At that time, at the end of 2020, 2021, the UK had 90 long COVID clinics that were funded and set up by the government across England, not in Wales or Scotland, but across England. And even to this day, 4 years on, you still got a lot of those clinics, the expertise and the experience that have come through. But what we've realized now in the last year or so, with not enough people testing for COVID, with the sort of the weakness of the strain, probably it not being as potent as the first two waves, there has been unfortunately less of a rise in acute COVID. And what that has meant is that the media and everything that's happening in the world right now has meant that we are not able to talk about the really disastrous plight of the long COVID patients. Even yesterday, I had a patient coming to my clinic with fatigue, with pain, with breathlessness, with all these symptoms 4.5 years after their acute COVID episode. And the challenge is that in the UK, when we were doing the research, and we still are having areas of research, but the funding is also reduced a bit. So there is this fragmentation that's happening. The research is happening, but we haven't as yet got a clear biomarker. I'm hoping that there are two pieces of research, one, both of which I was involved in, one that has come from the University of Reading. We were actually looking at pain within long COVID, which is very, very common. About 70 to 80% of our patients experience pain of a different kind when the virus affects the nervous system significantly. Does not damage it, but changes how the signaling occurs there. So that was what we studied. We took the blood of patients with COVID who had pain, and then we had the blood of patients without COVID. And we were also doing a sort of functional MRI. We were seeing which parts of the brain light up when they were experiencing pain. And we've done that study for about 18 months now, looking at a cohort of about 50 to 80 patients. And hopefully, in the next 3 to 6 months, we will have some signal and idea of whether there is a particular blood test or something that we could do specifically with regards to pain and long COVID. So I'm hopeful that that will come through. And there's another research study that the result will come out hopefully in the next few months, where we were comparing a few drugs like the antihistamines or steroids or the blood thinning medication, just to see if one of them could emerge as a better potential simple drug that could be repurposed and used for long COVID patients or preventing acute COVID from becoming long COVID. I think these are still emerging areas. There are a lot of labs in the US who are hoping to have some research come through. But that has been the big challenge. As you rightly said, there's been lots of money that's been put in, but we've struggled to come out with a clear biomarker. And that's something that we need to change as a community, as an academic and research and clinical community for our patients.
I'm wondering, actually, first, I just want to clarify because I was laughing earlier when you're talking about your illness, and I thought you said you'd had your share of man flu, but then I thought after, oh, he might have said bad flu. So sorry.
I was trying to make a light-hearted comment to say that every time I was feeling so tired, my wife would say, "Oh no, you're just catching man flu again, aren't
Okay.
you?"
Okay.
I did say man flu, and it was
You did? Okay, good.
but I tell you, that was by far
Yeah.
the worst illness, and I think a lot of my patients who I saw at that time, what was surprising was you'd think that people who had a very bad episode of COVID are the ones who'd be left with long COVID. But has is a lot of the stories that have come on your side, a lot of patients who've said it, people have very mild infections. In fact,
Yeah.
90% of the people who came to my long COVID clinic did not even go to the hospital or see their primary care practitioner. But 2 to 3 weeks later, they started experiencing symptoms from multiple organ systems that haven't gone away for years.
Yeah. I'm wondering if you're seeing overlap because, as you know, I had ME/CFS, and what you might not know is mine started from a really bad flu, not a man flu, but a but a
Okay.
really bad virus. Yeah, and it took me about 10 years to recover. So, are you seeing in your work overlap or benefit of talking about ME/CFS and long COVID and chronic pain under one umbrella? Because I know definitely for the people who are following my channel, they seem to be getting a lot of benefit from using those different strategies, regardless of their specific diagnosis.
I think within the first 4 to 6 months itself, my physiotherapist that I was working with at that time was having these conversations because she was a specialist pain physiotherapist who was helping fibromyalgia patients and ME and CFS patients. And some of the fundamental principles of pacing appropriately post exertional symptom exacerbation management, those principles were proving to be very useful in advising the long COVID patients on how to pace their physical activity. We were very careful. And certainly by that time, I was very much a proponent of not believing in the graded exercise thing that was such a problem for the MECFS community. In fact, we spoke to a few of the patients with MECFS who were in our clinic at that time, got a bit of advice from them itself on how we can have conversations with our long COVID patients. And I must say, I think it was something that we approached carefully because there was a period of time where the long COVID patients did not wish to be associated or felt that by becoming part of the MECFS, somehow they would be psychologized and not be looked after and validated and listened to and biologically investigated. I think from 2022, maybe even 2023 onwards, there's been a much better acceptance across the community that there are so many important advances and changes in MECFS that could be easily supportive for the long COVID community, and vice versa. The newer techniques or drugs or things that were being trialed in long COVID were now being trialed in MECFS patients, and some of them were noticing a change and an improvement. So I think what has happened eventually in the last 12 to 18 months is that there's been a lot of symbiotic support and there's been a lot of overlap and benefit that both communities have had from sort of aligning themselves. And certainly in the UK, the research and even at government level, a lot of long COVID services, when they've come up to the 2024, the UK government has said, well, you guys, you've gained a lot of experience from looking after long COVID patients. Now that long COVID is on its way down, the number of referrals are coming down. Why don't you change your service and start accepting patients with ME, with CFS, with fibromyalgia, so that you can still provide a much more multidisciplinary integrated service with physiotherapists, where possible, with occupational therapists, with support from nutrition or dietitians, support from psychologists for the mood element, and actually having a physician who could advise and look at it in a much more holistic fashion. Because by that time, even the main guidelines in the UK, which is usually brought out by an organization called NICE, they were actually taken out the old MECFS guidelines, which had talked about graded exercise therapy and psychology. They had removed their entire guideline, brought a new updated guideline, which specifically emphasized that all patients need to be properly investigated, need to be properly validated, explain what's happening, talked about various aspects of, mitochondrial changes or alterations to your health, to your immune system, to your nervous system. And then using the techniques of pacing, psychology support, mood management alongside mainstream medications or appropriate interventions and investigations as needed. So that's a really welcome change to the community in the UK.
Yeah, it's been a silver lining of a really horrible situation for people with ME/CFS that we've been ignored for decades. And now at least some people are paying attention and we're benefiting from the research that's coming from these other conditions as well.
Yeah.
I'm wondering, because you mentioned at the beginning that your approach to treatment has shifted from more, medication or surgery to more a trauma informed, looking at environmental factors, social determinants of health. So, can you tell us about that?
In some ways, I've got to really pay homage and my sort of respects to people like Howard and Dave who've come on your channel there. I'm as influenced by them and their teachings and the studies they have brought out with regards to pain science, with regards to the role of adversity and childhood experiences, the ACEs literature that Dave talks about, and the work that people like Gabor Mate have done around trauma. Because when I looked and understood those studies, and I said, here I am the lead of a specialist chronic pain clinic in the United Kingdom. We, as a district general hospital that I was working for at that time, we were the main referral hospital on the National Health Service for about 500 to 600,000 patients. And I was the lead of the chronic pain service, seeing about 1,000 to 1,500 new patients every year. I wanted to find out, well, how common is adverse childhood experiences and trauma when they come into chronic pain, when they come with chronic pain, whether it's back pain or neck pain, when they come into my clinic. And I was shocked, Raylan. In just a 10-week sort of audit I did of every new patient that came to my clinic, I just asked them these sort of the ACEs questionnaire, the 10 questions that came through. And it blew me away when patients actually, if you ask them the right way, they volunteered the information without really opening up a can of worms, without really increasing the need for more behavioral support or counseling or anything. They were just happy that someone was ready to listen to them. And when I explained to them why that kind of could make your nervous and immune system more vulnerable if you've had trauma as your nervous and immune system was developing, you underwent persistent, intense trauma, whether that's abuse or neglect or emotional or familial dysfunction, how that can make your nervous and immune system more hypervigilant and looking out for threat, and why that can sometimes make the risk of chronic pain much higher. It was an aha moment for a lot of them. And the data, just my simple data from my own clinic at that time, showed that up to 35 to 40% of the patients coming to my pain clinic were having up to 3 to 4 adverse childhood experiences at the time. And we were not doing anything. I was talking about opioids and prescribing opioids. I was putting them forward for some injections or nerve blocks without realizing how to communicate and appropriately frame my communication. If their nervous system was already vigilant and hypervigilant, if I didn't communicate it right, I could potentially be making their pain worse. These were things that I was oblivious to for the first 5 to 6 years of my practice. And what's changed in the last 6, 7 years, once I've understood that picture, is to say, well, how can I be more sensitive in both in my communication, in my language, and in my decision making when a pain patient is sitting in front of me in my office? How can I, if I'm going to give medications, how can I be safer and make sure that they are going to be benefiting from it and not having any of the untoward side effects? So there's a lot more trauma based awareness in how I frame my communication, my consults, and how I frame my letters to my primary care colleagues or to my other colleagues or nurses. And in the last 5 years, I found that being really helpful, both for my patients, for myself in terms of how I feel about my practice. And actually, that kind of approach has meant that it's not enough if I just think about what I'm going to prescribe or inject or suggest to my through my physio or my psychologist. I actually need to know their ecosystem, because if their nervous and immune systems are still ongoing trauma is happening, whether there is their social determinants of health, whether it's their job, whether it's their economic situation, their situation in terms of their physical environment that they're part of. These are all things that I then have to at least be aware of. I may not be able to change them, but at least if I'm aware, I ask about it, I can then work with them to make a plan that's more informative, that's more supportive. And that actually can mean that even if I were to give a drug or an injection or a pain management program, I have a chance of it succeeding. Because that was another factor I found, that my colleagues and me, we would give a 6 or an 8 week or a 12 week pain management program where patients would come weekly, they'll attend it, they'll go. But once, and they'll make the improvements, they'll change their habits, they'll pick up new habits when they're part of the program. But once they go back to their community, to where they come from, if we've not accounted for what might be happening in primary care closer to their home, then every advantage, every benefit they've made in the program is short-lived. They would then be referred back and they would be bounced back into our referral service within 3 to 6 months. And they'd say, well, actually, you know what? We didn't have the time to practice what we did. We couldn't eat healthy because this happened. Some other stress happened and they couldn't stick to their habits. And we were back to square one. So that's where I found the field of lifestyle medicine. And I don't know if this is something that has come up on your channel or you've had other speakers on there. This is the most sort of rapidly growing medical specialty in the last 5 to 8 years in the UK, and I think in the US as well. And I'm sort of one of the members of the British Society of Lifestyle Medicine, a trustee here. I find the principles of lifestyle medicine, wherein the focus on the social determinants of health, the focus and the understanding and the mapping of the 6 pillars around nutrition, around healthy connections, around sleep, around activity, inquiring about it and making a plan, and then actually coming up with a plan of coaching and supporting the patients to say, how can we make this sustainable, not just in seeing me in the office, but how can you have a set of plans in place to keep it ongoing in the community? Does it include your family? How can we include your friends? Do we need to have cafes? Do we need to have some kind of ongoing support? And I think that's been the focus of my work for the last 2 to 3 years now, is to say, well, it's well enough for me doing it in a clinic. How can I actually take this and go upstream and work in primary care with the GPs, with the primary care practitioners, with health coaches, with social prescribers, with community workers? How do we set up systems with voluntary sector and charities in the community to make a difference and to sustain that difference for our patients? And that doesn't have to be just for chronic pain. Actually, if you think about it, it can be for any long term condition, for mental health, for obesity, for diabetes, blood pressure. The opportunities are there. And I think that's what I'm doing right now in my local area.
I could not possibly be more excited about this field of lifestyle medicine. I do hear people occasionally talk about it, but not very much at all. But I have goosebumps listening to you talk. And I'm just thinking of so many people I've interviewed who have credited their recovery, their symptom alleviation to things like, I didn't realize how alone I was and how I was craving a community. And then I built up this community and I started feeling better, which sounds a little bit ridiculous to a lot of people that aren't used to thinking that way. They think, well, this really sort of delegitimizes my condition, or like having friends isn't going to fix this. And, perhaps not for everyone, but so many factors of looking at childhood trauma, at looking at repressed emotions, at looking at, living a life not in line with one you want to be living, living unhealthy environments, unhealthy relationships. We absolutely know that our emotions and our stress, how we feel, impacts our physical body. I interviewed someone recently, Nicole Sachs, who was saying, I'm teaching you what you already know. I'm telling you what you already believe. Like You have a stressful day, you get a headache. Like we know all these different ways that our emotions impact how we feel. It's just expanding that to think about actually, wow, that it impacts so many more things than we realize. So I think this is incredible. Absolutely incredible.
But no, absolutely. And I think the work of Howard, of Gabor Mate, of Nicole as well, I follow her, and a lot of others have shown how important regulating the nervous system, giving safety, giving security is important. But that is at almost at a personal level. We are hoping that when you do emotional awareness therapy, when you do internal family systems, when you do any of the so many techniques about regulating your nervous system is brought into place, it still is almost we're saying, okay, you need to learn how to do it. And I could coach you to do it because you can do it and it's all within you. But what we now realize is it's not often an inside job alone. The question I nowadays think about is it's not what's inside of you, but actually what are you inside of? And if the system around you is not able to let you live your best life because of the various structural changes, then I think as healthcare leaders, as professionals who understand and can see both sides, I feel that that's a responsibility that I need to stand up for and actually say, how can we create a garden and cultivate the soil so that the plants can grow healthy? Because we've talked about it, the terrain is so important. We need to create the ecosystem where this flourishing and thriving can happen easily, and it takes a long time for that internal behavior change to happen. People need to hear the same information about 7 to 11 or 12 times before change can happen. So my thought is, as a system leader, how can I ensure that all of the clinicians who are looking after a patient have a similar message, have a system that makes it easy for change to happen and change to be sustained? And I think that's a very important role that we don't forget, that how do we make the system easier? Because otherwise, and I think I would recommend your readers to listen to the work of Lisa Feldman Barrett. I don't know if you've come across her yourself. She's a fantastic researcher based in the US, I think somewhere near Boston side. But I think she's written a book called The 7.5 Lessons from the Brain. So she talks a lot about emotions, about how the neural circuits are changed and what the brain is ultimately needing to do, about energy, about conserving energy, about trying to keep the energy balance and the body budgeting. And so a whole lot of neuroscience and pain science is all converging into this part to say that if you can make the energy for change as less as possible, then that change is likely to happen. But if somebody is in a system where to change something, they have to expend a lot of energy, and that means that the system is not aligned in a way, then whatever they try to do is very difficult to sustain. So changing the energy of the system so that the individual expense as little as possible is hugely important for behavior change or system change to happen. And I feel that as a system leader, as a person who set up services, this has been my reflection that we as healthcare professionals have a big role to help our patients not only get healthy, but actually then stay healthy as well.
So, what would be your advice or your suggestions for people who are listening, watching, who are facing chronic pain, long COVID, ME/CFS, and they're trying to navigate the conventional medical system? What's the best way for them to do that? Or what should they be seeking out? What questions should they be asking? How do they do this?
Wow, that is a solid question. You thrown me at the deep end there.
As I heard it coming out of my mouth, I thought, wow, I've really set you up here. I'm sorry. That was
Let me
But that's
think
the
about
reality
this.
of what
It is.
people are facing. They go to their doctor and their doctor's like, what are you talking about nervous system regulation? What is lifestyle medicine? Many physicians, that's going to be the answer that they receive.
Absolutely. And I think you are very right. So what would I advise? I think the first thing is coming from the science of pain and long COVID is that the nervous system is capable of recovery. So, hope, which has repeatedly come on your channel, is going to be the first thing I would want to ask any listener here with these conditions to have. Maintain that hope that recovery is possible, because neuroplasticity is something that's very real and that can happen. The second is actually realizing that you are not alone and that there is a community. And I think people like yourself who've created that community, apps like Curable, which have brought about that online community. And similarly, in the UK, there are a lot of lived experience patients who have really wanted to pay it forward. They've set up these kind of pain cafes, they've set up these kind of opportunities for them to come together and provide that sort of mentorship and companionship and self-management support in the pain space, in the long COVID space, in the functional illness space, I think, and the MECFS space. So I think just about reaching those conditions, reaching those communities gives you the confidence that you can be armed with a lot of information, because you're very right when you say that you are not sure which healthcare professional you're going to meet. Are you going to meet someone who's enlightened and understands and is willing to validate them? Or are you going to meet someone who's got only 10 minutes and have got their own traumas and their own dysregulated nervous systems to manage, working in a system that doesn't reward them, and they have to work in a different set of incentives? So, at a trauma compassionate level, my own colleagues have their own challenges that they have. So, if you run into that professional, then you need to not come out of there feeling hopeless that you're not being listened to. So I think, first of all, having that bubble wrap of a community that's there to support you, the information that you need to upskill, maintaining that hope and recovery, that neuroplasticity can play a role. I think those are the first two, three big pieces of advice I would have. And then you take it forward to your professional to see where they stand, how willing they are, how compassionate they are to listen to what you need. And that would be my next step. Then you take it, because that's a whole different system in itself.
And thank you for reminding us that doctors are human beings too, because I think us laymen's expect you all to be perfect and all knowing and never have a bad day and, just never have your own stuff going on and know every piece of information that exists in the universe. So, everyone's just doing the best they can with where they're at.
And you really, I think I just should say that I'm as guilty of that, Raelan. I realize that at times at 8 o'clock or 9 o'clock in the morning when I'm starting the clinic, I feel so chuffed and I can have long 45-minute, 30-minute consultations become 45, 50-minute.
Yeah.
But as I approach lunchtime, also as I approach evening 3:30, when I realize I've got to go at 5 and pick up my daughter from school, I realize that I'm getting abrupt. I realize that I'm getting short in my messaging, short in my understanding and my patience. And I realize that's not what I want to do or want to be. But I know that this happens to everyone. And indeed, there's evidence to actually say that judges who are handing out sentences of imprisonment or death sentences, you really don't want to go before such a judge before lunch. And your best chances of getting a lenient sentence are after lunch or early in the morning.
Yeah. We're human. Everybody's human. Yeah. That's a really good thing to point out. And the other amazing thing for right now is that, like you said, the information is there. And we talked about interviews with Dr. Howard Schubner, Dr. David Clark, and Nicole Sachs. And in addition to this one with Dr. Ravindran, they are must-watch interviews. So I'll link those in the description, because that is the beautiful thing, that even if your physician isn't completely up to speed, you can still get that information. You can bring it to them, you can work with them, and to not give up. I think there's a tendency when you're feeling dismissed, or you're feeling like your doctor isn't getting you anywhere. I know I felt this way, and I've interviewed many people that just sort of wash their hands of the whole medical system, thinking there's nothing to offer there when there absolutely is. So it's easy to get jaded, but just, find someone who will work with you. Find someone who's like willing to watch the video and hear what you're bringing into them, and just, work with you and say, I don't have all the answers, But I'm here and let's do this together. And that is, I think, all any of us are hoping for.
Absolutely. Absolutely. And I think I
Incredible.
would echo that absolutely, Raylan, that I have so many patients who have immensely benefited from just seeing the content that you put out, the various other lived experience channels that I signpost to, just knowing that they're not alone, just knowing that their stories resonate with some of the stories on your channel or from Curable's recovery profile. That itself
Yeah.
is a big boost to how they feel and a confidence in whether they can recover or not.
Amazing. Thank you so much, Dr. Ravindran, for being here. This has been incredibly enlightening and just so wonderful to know that you're out there helping people. Yes, thank you for all that you do.
Thank you for having me once again, Raylan, and have a good weekend and take care.
And thank you as well to everyone watching, listening. Looking forward to your comments and hope to see you in this next interview, one of the ones that I mentioned that I'll pop up on the screen here.